I'm going to present a complex case to you today involving the knee, specifically the patellofemoral joint and femoral condyle for complex treatment. This is a 26-year-old female who has right knee pain. She has a 10-year history of right knee pain that's been worsening over the last 3 years. Her history is that she had a previous ACL reconstruction and a bone marrow stimulation technique of the medial femoral condyle. And her chief complaint is anterior knee pain, crepitus, and swelling. She indicates that she has trouble with activities of daily living, such as stair climbing, and she's actually had to switch to a sedentary job, previously working as a perioperative nurse. She's had no relief with non-surgical treatment, including injections. Her range of motion is normal from 0 to 130 degrees. She has no effusion. She has significant crepitus with active extension and pain with patellar compression. She has mild tenderness to palpation of the medial femoral condyle. And when I measured her tibial tubercle-trochlear groove distance, it was approximately 20. If I asked her what her primary goal is, she would say that she would like to have substantial reduction in pain and the ability to return to normal work. Her imaging is pretty unremarkable. You can see on her right knee that she had a previous ACL reconstruction. She has preservation of her joint space. Her lateral view shows no significant patellofemoral change. She has no significant patella alta. And there's evidence of previous hardware from an ACL reconstruction. Her MRI, including the coronal, sagittal, and axial images, show specifically, if you look at the middle sagittal image, there's some femoral condyle change, maybe some sclerosis, some overgrowth, maybe bony overgrowth at the cortical margin. On the axial view, there's a suggestion of a defect within the trochlea, although there's no subcondylar edema. Most importantly, at the time of her index arthroscopy, one can see her medial femoral condyle has some sclerotic change after debridement. This is the area that underwent previous marrow stimulation. This is about a 20 by 20 medial femoral condyle defect. Her trochlea has a 22 by 25 defect, and her patella has a 12 by 15. So these are central, relatively contained defects with normal surrounding cartilage and healthy bone, in contrast to her medial femoral condyle, where the bone has been compromised by a previous marrow stimulation. So this begs the question in terms of what treatment. We know now that her index confirmatory arthroscopy showed those 2 or 3 defects. So we indicated her for a combined definitive treatment, which would include an osteochondral allograft of her medial femoral condyle and MACI of the patellofemoral joint with an associated tibial tubercle osteotomy. The decision-making for a case like this is actually pretty interesting because we're looking at a failed previous treatment of her medial femoral condyle and virgin treatment for her patellofemoral joint. At the time of her arthroscopy, I performed a biopsy for future MACI, and this allows us time to plan the subsequent treatment. Keep in mind that the knee is an organ, and it doesn't necessarily only relate to the cartilage defect, but it relates to the biology of the bone. It relates to alignment issues and ligament status and meniscal status. In this case, the meniscus is normal. She's previously reconstructed and has an intact ACL. She has no longitudinal malalignment in terms of the tibial femoral axis, but she does have patellofemoral malalignment. And we know that patellofemoral realignment, such as a tibial tubercle osteotomy, can relatively unload the patellofemoral joint and serve as adjunct treatment to definitive treatment with MACI. So on to her surgical procedure. This is a hemicondyle of the medial femoral condyle. It's a fresh osteochondral allograft, a cylindrical plug 20 by 20 with 6 to 7 millimeters of total depth, including about 4 millimeters of bone, is the plug after final preparation with the cylindrical reamers. We pulse lavage it with 3 liters and ultimately we'll soak it in bone marrow concentrate to hopefully augment the host-donor interface. This is the open procedure. It's a vastus sparing approach. We expose the medial femoral condyle through a limited arthrotomy. One can see sclerotic bony overgrowth along the medial femoral condyle from previous marrow stimulation, and we treat it definitively with an osteochondral allograft that you see here. Switching to the patellofemoral joint, where we perform matrix-associated ACI and a tibial tubercle osteotomy. We can do this through a relatively small incision by everting the patella. We can see the central inferior defect, which is a good location to be unloaded by a tibial tubercle osteotomy. Similarly, we see some fibrocartilage fill in the trochlea and grade 4 change with good, healthy surrounding cartilage. In this instance, we use a custom cutting guide to harvest and procure the MACI for both the patella and the trochlea. In addition, we see a cutting guide placed, the tibial tubercle osteotomy system, to perform a very objective anteriorization with a little bit of medialization to respect the TTG of 20. Here's the defect being prepared in the patella. As you see here, a circular defect. And here's the defect oblong in the trochlea. And finally, we see the implant in place with fibrin glue on the patella, and the implant in place in the trochlea, also with fibrin glue for final security. So at follow-up, at 8 months, which is relatively early in the scheme of this type of treatment, her pain on the medial side was actually eliminated. She did not complain of any effusions. She had mild pain with stair climbing and initiating running and higher impact activities. And she would say she's satisfied and has reductions in pain that are improved compared to her preoperative state. I think the important thing to understand here is how to manage patient expectations. This can continue to improve over 12 to 18 months, but we do allow patients to return to high impact sports as soon as 8 months, assuming they can tolerate it after undergoing this procedure. So just some final considerations when contemplating definitive treatment for a patient such as this. When treating failed defects, it's important to understand the biology of the subcondylar region, as well as the subcondyle plate. We can combine technologies to match the pathology in the previous treatments, especially with focal lesions. In this case, we chose MACI, mainly because it's a good definitive treatment for the patellofemoral joint, where we can preserve the architecture, and we're not as sensitive to geographic or topography changes that we have to match to an osteochondral allograft. Similarly, on the medial side, having undergone previous marrow stimulation, MACI is maybe a little more challenged when the subcondylar bone is changed, although we know if there's minimal subcondylar change, we can still do MACI in that location. So we offered her a medial from a condyle allograft to salvage the previous marrow stimulation. As I indicated, patient expectation management is critical. It could take 8 to 12 months to achieve a good outcome, and these outcomes can improve over the course of a year and a half. And then finally, as I mentioned, thinking about the knee as an organ, not just as a cartilage defect, but consideration for the malalignment, consideration for meniscal status, and ligament status, all are very important when contemplating definitive treatment. Thank you, and I hope you enjoyed this on orthoregeneration case.